patellofemoral instability. Over to you, Dr. Joshi.
Thank you so much, Hitesh. Hi, guys. We are going to talk about patellofemoral instability today. As you know, I'm Mr. Joshi, one of the knee surgeons practicing in Wrexham Hospital in the United Kingdom. It's a beautiful part of the world, and you're all welcome if you want to observe any surgeries down here. Patellofemoral joint is a very complex joint, and we know there are quite a few patients who do have problems with the patellofemoral joints. Now, this topic particularly looks at patellofemoral instability symptoms. So it's not pain, it's the instability that we are going to concentrate on. The pain could be secondary to the instability issues, but primarily this talk is about patellofemoral instability. Patellofemoral joint itself, it's called the left ventricle of the knee. It is a very, very delicate part of the joint. And if anything goes wrong with this part of the joint, the patients have got lots of trouble. There are patients who come to me with previous various surgeries, which doesn't help them. And then it just makes things worse when you treat these kind of patients. So we'll go through all this topic in detail, and we'll talk about the current concepts as to how thinking has changed over the past few years as to how we deal with instability issues of the patellofemoral joint. So it's quite commonly seen in female adolescent patients. You will see quite a few people walking down the corridor in your hospital with in-toeing gait, broad pelvises, valgus knee attitude, and it's a part of a syndrome. So it's not just the patellofemoral joint. You have to look at this patient as a whole. So they may be hyperflexible. They will have broad pelvises, internal femoral torsion, increased anteversion of the femoral neck, valgus attitude of the knee, and external tibial torsion. So all these things can lead to a situation where the forces acting on the patellofemoral joint, which are not favorable for the knee, and that leads to dislocation of the patellofemoral joint and then residual instability of the patellofemoral joint. And we'll talk about all these anatomical factors and the pathoanatomy in detail as we go ahead. Once a dislocation of the patellofemoral joint occurs, the chances that it is going to recur or redislocate or cause residual instability is quite high. After the first dislocation, it's high as about 1 in 5 people. If there are risk factors associated with these kind of injuries, and we'll come to the risk factors in a minute, then the recurrence rate is very, very high, especially in trochlear dysplasia patients. It's about 60%. The recurrence rate after second dislocation is very high as well, even without any risk factors. So it's about 50%. After the first dislocation, we have to look at the articular surface of the patellofemoral joint. More common than not, as the patella dislocates over the lateral femoral condyle, it takes the chip of the cartilage. And with that chip, you may have an osteochondral fracture as well. And this is very, very important to recognize in the first instance, because if you treat it there and then the problems associated with these kind of injuries are lesser after a few years' time. Because if you get a patellofemoral arthritis in younger patient group, it's very, very difficult to treat. And they end up having residual instability symptoms, especially if it's associated with dysplasia. They will have these symptoms and they will present even late with articular damage. And then you will have to deal with both the problems together. Now, the patellar instability could be lateral or medial. It's always lateral in my experience. The medial instability only occurs if you have dealt with the lateral instability surgically. So if you have done a lateral release because of perceived lateral structures tightness, then it will lead to iatrogenic medial instability. And we'll come to that. And that is the take-home message from this talk is, there are lots of people still doing lateral releases for these problems. And this is what we need to stop doing. So the anatomic of the patellofemoral joint, there are very specific things to look for. One is the trochlear groove. So as the trochlear groove lessens, the chances of instability will increase. And that's quite, straightforward. The other thing is the height of the lateral trochlea. Now, if you have a very shallow lateral trochlea, then that will lead to increased subluxation. As we all know, the vectors on the patella is always laterally directed. And that is the whole function of the knee and the way we were developed when we became bipod. So when we became bipedal, we had abnormal attachment of the quadriceps tendon and the patellar tendon, and that has led to an angle which is what we call as Q angle, which lead to a vector on the patella which is directed laterally. So the chances that it is going to dislocate if there is a lower height of the lateral trochlea is quite high. So the structures on the medial side are very, very important. The most important part is the medial patellofemoral ligament. And the medial patellofemoral ligament accounts for about 60% of restraint to the lateral structures, or the lateral vector, as we call it. A higher patella is another risk factor for recurrent dislocation. So if the patella is higher up, then the constraint around the patella is quite less because it's not in the groove. And that's the reason it will sublux. It will not engage into the trochlea as well. Very often than not, you will find the patients with high patella will have a dysplastic trochlea because the trochlea itself hasn't developed as it should have. And that's where it comes a concept of contained patella. Similar to the dysplastic hips, if the femoral head is not in the acetabulum, then the acetabular development is affected. Same analogy appears to be there in the patella and the trochlea. So if the patella during the development of a fetus is not contained into the trochlea, then it will lead to a dysplastic trochlea. So there was a bit of conundrum whether it's like a chicken or egg. So was it the dysplastic trochlea which had led to abnormal patella, or is it the abnormal patella which has led to a dysplastic trochlea? And this concept has come with various experiments in rats where you cut the MPFL in very young rats and see how the trochlea develops after that. So because the patella did not contain into the trochlea, the rats who had sectioned MPFL developed a dysplastic trochlea. So it's a very important concept to understand. And hence, if the patella is very high riding, then it's not contained, and that will lead to a developmental dysplastic trochlea. So the way we define a shallow trochlea is when the sulcus angle is more than 145. So, as it flattens, and this is a very arbitrary number. So we just need to be cautious about, if it's what if it's 146, it's still shallow. So those are the things that you will have to consider when you call it as a shallow trochlea or not. But this gives a rough guide for us who are very objective in seeing what is the shallow trochlea is. So the definition, it's about sulcus angle more than 145 degrees. Now, the other take-home message from this talk is this, that a true lateral X-ray of the knee is the important important one in all the investigations. That is going to tell you what to look for. Historically, we were looking at the patellofemoral joint from the skyline view. And the skyline view, and we will talk about it, is not the diagnostic feature because it changes according to the flexion of your knee. So as you flex, the dysplastic trochlea is quite proximal. So as you flex, the patella is going to engage into the normal trochlea. And hence, when you look at a skyline view, which is in flexion, you will have a normal view of the patellofemoral joint, which is not the case, obviously, in patients with instability. So this is what you need to take home, is a true lateral X-ray of the knee joint is quite. How do you know whether it's a true lateral X-ray? What you have to look is the overlap of the femoral condyles. So if the posterior condyles of the femur are overlapping with each other, it's the true lateral X-ray of your knee joints. And if it's at 30 degrees of flexion, that's when Derotation has described the different type of dysplastic trochlea in this view. And this is what we are going to look at. So if you follow the lateral femoral condylar margin, so that's from the posterior aspect of the femur, all the way to the anterior, there is a small dip here, and that is called the terminal sulcus. So on a true lateral view, you can distinguish between the lateral and the medial femoral condyle. And as you go further, this margin will then confluent over the anterior margin of the femoral cortex. And this is a smooth transition. That is normal. It's very important to understand what is normal and then come to what is abnormal. If you follow the Blumenstadt line, which is there, it then carries on anteriorly. And this is the deepest part of the trochlea. And this shadow is the central trochlear line. And usually it follows and does not touch the anterior margin of the femoral condyles. And it carries on to be confluent to the anterior margin of the femur. So these are the normal landmarks of lateral knee X-ray. And this is what we need to look for. So Derotation classified the dysplastic trochleas into 4 types, depending on how much dysplasia there is. So the type A is a shallow trochlea. So the sulcus angle is more than 145 degrees. And in this case, you will see the crossing sign. So if you follow the Blumenstadt line and then take it anteriorly, it will then touch the anterior margin of the femoral condyle. And this is the crossing over sign. Remember, in the normal knee, it would go and not touch the anterior margin, and it will just be confluent with the anterior femoral cortex. Yeah. So this is a crossing sign. It's an important landmark to see in a lateral knee X-ray. Similarly, as we go further, type B is a flat trochlea. So there is basically no groove. And in this flat trochlea, what will happen is the anterior margin of the femoral condyle will have a dip. So it's not smooth, there will be a dip, and it's called the trochlear spur. So this is the bump, and very important concept about the bump, because it's not about the groove, it's not about the depth of the groove, it's about the bump. And that is what we need to change our thinking to. So if there is a bump, which is the trochlear spur, that is a flat trochlea. Obviously, there will be a crossing sign because it's flat, plus there will be a trochlear spur, and it's called the ski slope sign. So it's like a slope in the skiing, and it just drops down, and then it's confluent to the anterior margin of the femur. In type C, the trochlea is convex, so it's not flat, it's also convex. And this happens when the medial femoral condyle is hypoplastic. So this is also a very different concept with the traditional concept we had, that the reason for trochlear instability is a lateral femoral hypoplasia or lateral condylar hypoplasia. It's not true. It's the medial femoral condyle that is hypoplastic. And when this happens, then you will have a, just go back, you'll have a double contour sign. So there will be a crossing sign, and then there will be another shadow down here, and that is the double contour. This other shadow is due to the hypoplastic medial femoral condyle. So in going back, so type A is just crossing sign, type B is crossing sign plus trochlear spur, type 3 is a crossing sign and a double contour sign. In type D, you got all the three. So you got the crossing sign, the trochlear spur, and the double contour sign. And this is what we call the cliff. So it's not only convex, but there is a bump in the trochlea. And that is very important to look for. And you can only look at this on the lateral view of the knee and not the skyline. So just to be clear, it's the lateral view of the true lateral view of the knee joint that is more important to decide whether this patient is trochlea is abnormal or not. Looking at the MPFL, which is the medial constraint of the knee. Now, this MPFL is a very strong structure. The tensile strength of the MPFL is around 200 newtons, so it is very strong because the forces that are acting on the patella are too strong. The quadriceps muscle is one of the strongest and the largest muscles in the body, and the forces acting, lateral forces, the lateral vector that acts on the patella is too strong, and hence the MPFL has to be strong to prevent the patella to dislocate laterally. It is attached to the patella. If you look at this picture over to the proximal two-thirds of the medial margin of the patella, and it's almost in the midline of the anterior and the posterior part of the non-articulate patella. So that is an important landmark if you are doing a patellofemoral reconstruction. This is an important point to note, and we'll come to the techniques as well. The other part that you need to know is the femoral attachment of the MPFL, and this is critical. It's critical because that will help in the isometry of the MPFL. So as the knee flexes and extends, the isometry changes of the MPFL. And if you have a look, it has got a very broad attachment over the patella and a tiny attachment onto the femur. So we'll talk about this anatomy when we talk about the reconstruct. How do you reconstruct the MPFL? Typically, the MPFL attaches to the groove between the medial epicondyle and the adductor tubercle. And this radiologically is defined by the Schottel sign. So basically, you draw a line over the posterior aspect of the femur, a vertical line at the end of, at the margin where the Blumenstadt line starts, and a second line over the posterior aspect of the femoral condyle where the cartilage will end. And it is here is the entry point or the attachment, femoral attachment of the MPFL, and this is critical. So if you know the anatomy, you will know how to deal with this problem. The other thing is patellar height. So there are various measures that have been come over the various years. The one that we now use is the Tatham Deschamps index, and that is very important because it has got the least inter-observer variability. So what it is the length of the articular surface of the patella to the length from the end of the articular point of the patella to the anterior margin of the tibia. And if that is more than 1.2, 1.3, then you have got a higher patella. And this can be measured on a MR scan as well. So, things have changed. So we now use Caton-Ducham's index, and it can be measured over the MR scan of the knee. And it has got good correlation with X-ray measurements. The other concept that has come nowadays is about the patellotrochlear index. And what it is, instead of measuring the length of the patellar cartilage to the length of the inferior pole of patella to the anterior tibial margin, we now think about what is the overlap between the articular cartilage of the patella to the articular cartilage of the trochlea in extension. And this is very important because if there is no overlap, then the patella is higher riding. That just indicates that patella is higher riding. Normally, you should have at least 12.5% of overlap. So if you divide the patellar articular cartilage into 8 parts, at least 1 out of the 8 parts should be overlapping the trochlear articular cartilage. And this is very important. Also to note, if you look at the axial views of the patella of the trochlea, if you see just the tendon articulating with the articular cartilage of trochlea, it probably is high riding. And that is another thing that you have to look for if you're assessing trochlea or patellar height. And the thing we need to know is the attachment of the patellar tendon onto the tibia. And that can be determined by the TTTG distance. Now, TTTG distance is very contentious issue because it changes with the flexion of your knee. So if you're doing an MRI scan of the knee will be in a flex position because the coil goes around the knee. So it might be different in different degrees of flexion. The other thing that is the issue is the trochlea is never normal. So it will be a bump here. So the way they try and measure the TTTG distance is by taking the highest point of the Roman arch. And that is very contentious because it doesn't correspond to the deepest part of the trochlea. And we know that if there is a trochlear dysplasia, the measurements of the deepest part of the trochlea is not going to correlate. So it does give a good guide for the Q angle, because the more the TTTG distance, the Q angle will be more. But there are downsides of measuring TTTG distance. If it's more than 20 millimeters, then obviously it is too much externally rotated tibia, and you may have to do something to the tibial tuberosity. But if you look at this another measure, which is called the TTPCL distance, it doesn't take into account trochlea. It doesn't take into account the degrees of flexion of the knee. And it does correlate quite well with the TTTG distance. So what it is, the distance between the central point of the patellar tendon to the medial border of the PCL. And that is quite reliable measure of, reliably measuring the distance between the TTTG. So there is a good correlationship, and this is what we tend to use nowadays. And it can be measured up on an MRI scan quite easily. The other thing we need to look for is the rotational profile of the patient. Now, it doesn't have to be in all the patients, but if you feel a patient who is hyperlax and has got in-pooing gait, it's always good to look at the femoral anteversion. Clinically, it is measured using the gauges test. So if you ask the patient to lie prone and then externally rotate the leg, at the point where the greater trochanter is the most prominent is the angle of anteversion. And that is important because, this patellofemoral syndrome, as I call it, has got a big variation, and at one spectrum you will have patients with a very high femoral anteversion, internal femoral torsion, external tibial torsion, and flat feet with planar valgus deformity of the foot. So those kind of patients does need to have a good understanding of the rotational profile of the knee. And in those cases, a CT scan slices of the hip, knee, and the ankle will give you the rotational value of the whole limb. And that can also determine what kind of things you could do to improve the symptoms of the patient. And obviously, there will be patients who are very hyperlax. The way we measure hyperlaxity is by using the Baton score. And I'm sure everybody will know how to use the Baton score to determine whether the patient is hypermobile or not. So that is one of the points that we have to consider when dealing with this thing. So in summary, you have a rotational profile, you have hyperlaxity, you have medial knee structures versus lateral knee structures, and then we have the trochlear dysplasia and the patella alta. So those are the four things in general that we are looking for, and these are the guides to tell us what we need to do to correct those points. So how would you, now that we know what the pathoanatomy is, it's now quite easier to know what to look for. So the clinical assessment is also critical. So we need to know what was the age at which the first dislocation happened, because the more years that have gone by, that will lead to the cartilage damage of the patellofemoral joint, and may lead to various other issues that you may have to consider, including treatment for the articular defect. The mechanism of first dislocation is also important. So whether it was a very minor injury that had led to dislocation, which means that the patient has got other risk factors, or is it a high degree of trauma which has led to dislocation? And in that case, it's probably not the anatomical factors, but it's just the trauma that has dislocated the patella. Frequency, how often does it happen? So some of the patients who have got chronic instability will say as soon as we flex the knee, it subluxes. And this can have significant functional and psychological impact to the patient. So they can't play sports, they can't go up and down the stairs, they can't do certain things, which is very important for them. And we need to gauge what the functional impact is. When you look at the gait, it's very quite obvious. They will have broad pelvises, valgus knees, planar valgus feet, in-toeing gait. So these are all the things that you look when they start walking in the clinic. Obviously, in acute situations, you will have tenderness around the femoral attachment or the patellar attachment of the MPFL, which can indicate acute rupture of the MPFL. And obviously, you will look for hypermobility by using Baton scoring. Other specific tests have been mentioned historically: patellar tilt test, how much the patella tilts, how that is. They used to determine the tightness of the lateral structures because of how to gauge the tightness of the lateral structures depending on how much patellar tilt they have. Sage mobility test is quite helpful. So the mobility of the patella should be at least 2/4. If it's less than that, or the medial side, then obviously there is more propensity of the patella to shift laterally. Apprehension test is also important. So you need a slight degree of flexion. If you try and recreate the subluxation, the patient will stop you from doing that. J's sign is quite obvious in trochlear dysplasia, where the patella will take a different route to engage into the trochlear groove. And depending whether you go from flexion to extension or extension to flexion, it's called J sign or reverse J sign. Obviously, rotational profile is important, and to gauge the femoral anteversion and the tibial torsion clinically is also important part of the clinical assessment of these kind of issues. Investigations, now that we have gone through the investigation part, the main three things that we are looking at is the trochlear dysplasia, the patellar height, and the TTTG distance or the TTPCL distance. And the radiograph will show, you can measure patellar height. You can look for trochlear dysplasia in the true lateral view of the knee joint. You look for a double contour, you look for the crossing sign, you look for the trochlear spur, and you can see all the three are there in this. So it's a type D trochlear dysplasia. And you have to look for whether there is any osteochondral fracture. You will, it's not uncommon to see a small flake of bone floating around the anterior aspect of the lateral femoral condyle in the lateral view in acute dislocation. And you have to look for that. So if you don't look for it, you will not see it. MR scan will and look at this X-ray. So this is a typical motion. These two are the same patients. So this is at 45 degrees of flexion, and this is at 0 degrees of flexion. So you can see it's not about the groove. It is about the bump. Yeah. And that's the reason a lateral view of the knee joint is much more important than a skyline view of the knee. Yeah. MRI scan will show all of these. So trochlear dysplasia, you can, see the trochlear dysplasia, whether it's convex or is it a big cliff, or is it shallow, or is it flat. Patellar height can be measured using Caton-Jew shams. A patellotrochlear index can be measured. A TTTG, a TTPCL distance can be measured. MPFL avulsions can be quantified, whether it's a patellar injury or a femoral injury, or is an interstitial injury. If there is a presence of osteochondral fracture, that can be looked for. So the MRI is the investigation of choice. So the treatment aims is to regain stability in these patients, and they will thank you for that. These patients are so debilitating because of the instability issues that as soon as you stabilize their knee, they are so thankful. Treatment of the chondral lesions, it's one of the important aspects of treating these patients because they are young. And if you don't treat these chondral injuries, they will have a patellofemoral arthritis. And that is incredibly hard to treat in young patients. So non-operative treatment includes stretching, strengthening exercises, short arc quadriceps extension. A long arc quadriceps extension are quite painful in these patients. So they are quite compliant with the short arc quadriceps extension exercises. The gait training is quite important, including gluteal strengthening and core strengthening. Close chain VMO exercises are important to improve the quadriceps tension. Taping, bracing will increase proprioception to the knee and lead to early rehabilitation. Proprioceptive exercises are important to gain the positioning sense of the knee so that they don't land in a certain way. Immobilization has got no role, so don't put them in a plaster or anything like that, because that is going to harm them more than helping them. So lateral retinacular release, so do not do it. So if you see a gazebo, which is on the 4 limbs of the gazebo and the tent kind of thing. So if the lateral side is gone, then it will either lead to the tilting of the tent or the medial side, which means there may be a medial instability, or it can exacerbate the lateral instability. So either way, a lateral release is going to worsen the problem than getting rid of it. So, it is not advisable to do lateral release in these patients. MPFL reconstruction, this is an anatomical reconstruction. So a broad base over the patella, the single base over the femur. The attachment of the femoral is very, very important, and that has been determined by the Shortall's point. So the line over the posterior border of the femur, along with the two vertical lines, gives us the Shortall's point. And you do it under X-ray guidance, find where the point is, and then attach the femoral part of the MPFL reconstruction. I tend to use gracilis tendon, bioabsorbable anchors over the patella, and bioabsorbable anchor over the femur. In children whose epiphysis is open, you can still do MPFL reconstruction, and you can go extraphyseal on the femoral side. Various techniques have been described for that as well. The important bit in MPFL reconstruction is the attachment. So it is important you know the anatomy and where to attach the MPFL. The other thing is tensioning. So it's very important you have the right tension over the MPFL. If it's too tight, that can lead to medial overload of the patellofemoral joint and can lead to medial side pain. The other thing is that we do and has been described extensively in literature is the tibial tubercle transfer. The anteromedial, so there are various things that you can do with tibial tubercle transfer. One is medialization. So only medialization if there is no issue with the patellofemoral cartilage, then you can just do medialization. The issue with medialization, just the medialization, is they tend to get arthritis very early. So nowadays, most of the knee surgeons will do anteromedialization, which is an oblique osteotomy, like the Ferguson's osteotomy, and that will lead to medialization as well as anteriorization of the tibial tubercle, which not only improves the TTTG distance or the TTPCL distance, but will also deload the patellofemoral joint. It is a very, very powerful osteotomy, and it will lead to very good outcomes if done correctly. The medial, too much medialization should be avoided at any cost. So if there is too much medialization, that can lead to medial, again, medial sided wear. Most of the time you combine these osteotomies along with MPFL reconstruction. The good thing about a tibial tubercle transfer is you can distalize the osteotomy. In this picture, you can see there is a distalization as well of the tibial tubercle, and that will lead to improvement of the patella height. So if you know the patella height, the TTTG distance, you can correct, and the articular health of the patellofemoral joint, you can then plan tibial tubercle transfer quite easily. And if there is type B or type D dysplasia, you can go for a sulcus deepening trochleoplasty. There's various techniques that have been described, and the most commonly used is the de Jure technique, or the shell technique, where you can just do a lateral arthrotomy and then take the shell and deepen the trochlear groove and then fix it with some anchors. This is a powerful tool as well in hands of surgeon, and essentially this is the proximal realignment procedure that we do nowadays. It can correct the TTTG distance as well, depending on the new trochlea that is formed. So if you want to medialize the trochlea, you can lateralize the trochlear groove as well. Depending on what the TTTG distance was pre-op, you can change it post-op as well. Typically, these kind of trochleoplasties are combined with the MPFL reconstructions as well. If there is significant rotational deformity of the femorotibial joint, what we tend to do is a proximal tibial metaphyseal rotational osteotomy. And as you can see, it is a complex procedure, but it works really well. Thank you very much. Any questions?
Thank you, Dr. Joshi. You have really gone into the depths, and it was a great learning experience for me as well. I was just listening very carefully to your lecture. Couple of questions. See, ever since Philip Shortall's research on MPFL reconstruction, there has been an explosion in MPFL reconstruction globally, right? So suppose if you get a patient who has only a patella alta, that is your canton Deschamps is more than 1.3, and you don't find any other radiological abnormality, what would be a procedure? Would you do a distal advancement of the, I mean, would you do a Fulkerson or a tibial tubercle osteotomy, or would you prefer an MPFL reconstruction?
If there is a patella alta, in my experience, there is always trochlear dysplasia. As you know, the patellar engagement is very important to develop trochlea. So if there is patella alta, there will be some amount of trochlear dysplasia. It will not be normal. So always take that into account. And once if there's pure patella alta and there is instability, which is very, very uncommon, you can get away just by distalization. But I can't believe there will be a patient with patella alta without any kind of trochlear dysplasia.
Yeah, the question is, I mean, I'm just being the devil's advocate, because is there a scenario where an MPFL reconstruction is contraindicated? The reason I'm saying is everyone is, I mean, people just don't look into the pathology. People go ahead for an MPFL reconstruction. So you need to know what is the contraindication for an MPFL reconstruction. That's why I asked you this question.
Yeah. So, when you do a MR scan, you look for three things. One is trochlear dysplasia, patella alta, and the TTTG distance, as well as the MPFL. So, all of them will have a stretched MPFL. Yeah. The MPFL that is reconstructed has got such a good strength. The tensile strength of the reconstruction is it's about 250 newtons. It is very, very strong. So people who just do MPFL can get away with it because it is such a strong reconstruction that even if you don't address other pathologies, it will work for a short duration and the patients will be really happy. But what happens with that, if you don't address the other problems, i.e. patella alta, then it will cause a non-isometric patellofemoral reconstruction, MPFL reconstruction. And that will lead to early failure and articular damage. And in very short term, maybe 5 years, 6 years time, the patients will be back to you with the same kind of issues. And that's the reason just doing MPFL without considering other parameters is a bad idea. So if you have got a patella alta, you will do a MPFL reconstruction because it will be stretched, but you have to distalize the patella. If you don't do that, the MPFL reconstruction will not work in the long term.
Okay, so suppose you have, suppose your canton Deschamps index is more than 1.3 and you have a TTTG that is more than 20. So then you're thinking of distalization as well as medialization, right?
Yeah, so most of the time it is the same scenario. So you will have an increased TTTG distance along with a patella alta. So you reconstruct the MPFL, you distalize the patella, and you antromedialize the tubercle. That is the strategy at this point of time. So
in your practice,
all the patients, sorry?
Yeah, in your practice, what is the percentage that requires a pure MPFL reconstruction and what is the percentage that requires an MPFL reconstruction with a tibial tubercle osteotomy?
Yeah, so it's about 80-20. So 80% of the patients will require just MPFL. 20% will have some other procedures attached with the MPFL. Now you need to understand the patients that come for just MPFL reconstructions, they have got a patellar dislocation that happens in their 30s or 40s. So, think about them as a group of patients who have lived with the abnormal pathoanatomy for such a long time before presenting to you. So if you do patellofemoral MPFL reconstruction for them, that's going to work without addressing other pathology. But if you have got a 20-year-old or a 25-year-old who has come in with acute patellar dislocation, then you will have to address the other pathoanatomy in them. And in my practice, it's more commonly MPFL reconstruction works for most of the patients, but in about 20% of the patients, it's not going to work. We know that, and you have to address the other pathoanatomy, and this is increasing. So initially I started with just doing 10% of the patients doing this osteotomy and trochleoplasty, but now you have increased your indications for this nowadays. So it is going to swing from one side to other, and it is ever changing science. And if you look at literature next year, it will be very different from what this year. It is an exploding amount of literature in these issues. So you have to be up to date with the literature.
Patellofemoral instability is something that changes every 6 months.
Yeah.
The literature keeps changing, so you need to be tracking the literature strongly. The other thing, see, since you've mentioned about trochlear dysplasia, the Deepening classifications well. Again, I think trochlear dysplasia per se is not a very common entity. If you look at patellofemoral instability as a whole, trochlear dysplasia is going to be a very small subset of patients, isn't it?
There will be mild dysplasia in most of the patients. And that can be, if it's just a flattened trochlea or a shallow trochlea, there is no need for trochleoplasty. But obviously, if there is a big trochlear spur or cliff, then obviously you have to do with the trochlea. If you don't deal with that, then they will get increased patellofemoral forces and lead to early degeneration of the patellofemoral joint. And in those cases, it's very, very difficult to treat them afterwards. So if you find a trochlear dysplasia, quantify it. If if it's quite significant, then go for a trochleoplasty instead of just doing a MPFL.
So DJOR A, you can just leave it alone. Maybe BC and
DJOR A is usually you left alone. Yeah.
Okay, and what is the incidence of trochleoplasty is a very demanding procedure, isn't it? And what is the incidence? How common is your practice? Do you have trochleoplasty?
Usually five trochleoplasties a year. So it's not a major work from a practice, but they do come. So you have to look for it. If you don't look for it, you won't find them.
Okay. The other thing is regarding the rotational profile of the leg. See, before you go for the surgery, do you take the CT scan of the entire limb and look for rotational profile at all levels, femur as well as tibial levels?
It all depends on the clinical assessment. So if in the clinical assessment you feel that the whole, if you are feeling for the anteversion of the femur, and if it's more than 45, you have to do something about it. You can't just ignore that. So it all is based on the clinical assessment. And as I said, there is a spectrum of patients, and the treatment has to be individualized to the patients. So there is no kind of, one thing works for everyone. So you have to individualize the patient. And if you feel the patient has got in-toeing gait, so if you ask and you will see these patients walking on the corridor, they will have an in-toeing gait with lots of issues with the hips. They have clicky hips, increased anteversion, increased external tibial torsion. You have to deal with those issues. Otherwise, it's not going to work. Just an MPFL reconstruction, or anything to do with patellofemoral joint is going to fail, and they will come back to you with problems and more problems after, if you just deal with that kind of issue. Because the problem is, as I said, it's a syndrome. It's not just the knee; it's the whole limb that has to be.
Yeah, it's called as miserable malalignment syndrome, isn't it?
Yes.
And the other thing is regarding increased femoral anteversion. Suppose you have a 25-year-old lady who presents with increased femoral anteversion, say around 40 degrees. So would you do a femoral derotational osteotomy prior? I mean, would you think that is the first procedure?
Yeah, I mean, rarely we see those, and they have got excessive femoral anteversion along with external tibial torsion. So you do dual osteotomies. So I don't do them. I take help of another surgeon who do them regularly. So you do a femoral derotation osteotomy along with the tibial derotational osteotomy. So it's like a dual osteotomy to correct the whole malalignment. They are younger patients, so you see them very young. So they will be in their teens when you see them, and usually it's the pediatric orthopedic surgeon I call in to deal with the malalignment issue. But you have to look for them.
Yeah. So in that case, don't you think we need to get an entire CT profile of that particular limb? Because you detect an increased femoral anteversion, you can detect external tibial torsion with the entire CT profile.
Yeah, so that's what one of the slides showed. So if clinically indicated, if you feel that no, it is quite critical to look for, mild femoral anteversion can be disregarded, but if there is significant femoral anteversion with external tibial torsion, you have to, and there are values. So if you look into the literature, there are values for the rotational profile of the limb, and if you feel that it's significantly derotated, you can do those surgeries. So the X-rays that I've shown for the proximal tibial derotational osteotomy, that can deal with the tibial torsion, but it won't deal with the femoral torsion. So if the patient has got hip problems as well, then it's better to deal with all the malalignment issues rather than just concentrating on the knee.
And at one point in time, maybe around 10 or 15 years ago, there was this procedure called Elmsley Trillat operation. That was a very standard operation that was being done. We do a lateral release and a medial plication. So do you think that's relevance is still there, that you do lateral release and a medial plication?
For me, no. So I know people still do it, but there is no role. M-Street Trialat, if I'm not wrong, is also combining tuberosity medialization as well,
Yes.
and that is just medialization, no enterization, and that has got higher risk of arthritis in your knee. So in my hands, it doesn't work, and I don't do it. Lateral release has to be very, very cautious. If you release the lateral side, you are making the patella more unstable. If you the reason you can do, what you tend to do now is do lateral lengthening rather than lateral release. So the lateral first layer, you can do a Z plasty and lengthen it, but release is a no. But even that is reserved for patients with with pain. So instability is very, very different from pain, and if the issue is instability, then you don't do it. But if it's a pain issue leading to lateral facetal degeneration and increased lateral patellofemoral pressure syndrome, and the patella is tilted so much so that the lateral structures are just not